All right, so you've shared some information about, well, a bit of a mysterious bodily imbalance, and it sounds quite puzzling.
It definitely can be.
So today we're going to take a deep dive into what might be going on there. We're focusing on something called syndrome of inappropriate antidiuretic hormone secretion. Bit of a mouthful, usually just called SIADH.
That's the one.
Okay.
And at its core, SIADH is about a hormone, ADH, that's antidiuretic hormone.
Hmm?
Put simply, it helps your body manage water.
Right.
Normally, it tells your kidneys to hold on to water when you need it.
Yeah.
But with SIADH, your body makes too much ADH, or the ADH it makes is just too active.
Okay.
So you end up retaining water excessively.
Okay, let's unpack that. You're holding on to extra water.
Mm.
Logically, you'd think, okay, maybe you just feel a bit bloated or something.
Hmm.
But this is where it gets really, really interesting, kind of the twist in the whole thing. This extra water actually dilutes the sodium in your blood.
Exactly. It's like adding way too much water to your squash. The flavor gets weak.
Uh-huh.
Same idea with sodium concentration.
That's the central paradox here, isn't it? And that's what we really want to get to grips with today using the info we have. Let's dive in.
Okay, so starting with ADH itself. Normally, it's absolutely vital for keeping your water balance in check.
How does it do that, typically?
Well, it acts mainly on the collecting ducts in your kidneys. Think of them as the final checkpoint for water. ADH signals them to reabsorb water back into your bloodstream.
Ah, okay. So if you're dehydrated, you make more ADH, pull water back, and your urine gets more concentrated. Makes sense.
Precisely. It's a really smart system. But with SIADH, that system basically goes into overdrive.
Right. It's just stuck in the on position.
Pretty much. It's constantly telling your body, hold on to water, hold on to water,
Mm.
even when you're perfectly hydrated or even overhydrated.
So for the person experiencing this, it's like their body is acting like it's permanently thirsty, even if they're drinking normally,
Exactly that. And this constant water retention triggers a kind of domino effect.
leading to the low sodium.
Yes, the most significant result is what we call dilutional hyponatremia. Low sodium natremia refers to sodium because it's diluted by all that extra water.
Yeah.
And you also get low plasma osmolality, meaning the blood itself is less concentrated than normal.
Okay, that follows. But here's the bit that seems really counterintuitive. Even with all this extra water sloshing around in the body, the urine becomes more concentrated. How does
Yeah.
that work?
It seems backwards, doesn't
Yeah.
it? But the ADH is still acting powerfully on those kidney collecting ducts.
Ah, okay.
So it's pulling water out of the urine and back into the blood so effectively that the small amount of urine that is produced ends up being very concentrated. Meanwhile, the blood gets more dilute.
Wow. Okay.
And there's another layer. This slight increase in overall body fluid volume actually suppresses another hormone, aldosterone.
And aldosterone usually does what?
Aldosterone normally tells the kidneys to hold on to sodium. So when aldosterone levels drop because of this mild fluid expansion,
You start losing sodium in the urine, even though your blood sodium is already low.
exactly, it's this paradoxical urinary sodium loss. Quite a complex feedback loop going slightly haywire.
It really is. Okay, so picture established. Too much water held back, low sodium in the blood, but weirdly concentrated urine with sodium being lost. What on earth triggers this? The list of causes seems, well, vast.
It really is surprisingly diverse.
Uh-huh.
It helps to categorize them, though. Broadly, we can think about central nervous system disorders, lung problems, pulmonary diseases, cancers or malignancies, various drugs, and then a sort of other causes bucket.
What's striking is how many different things can mess with this one hormone.
It really shows how interconnected everything is.
Let's start with the CNS, the brain and nerves. It kind of makes sense that if the control center is affected, hormone regulation could go wrong.
Absolutely. Things like a stroke, bleeding in the brain, head trauma, infections like meningitis or encephalitis, they can all disrupt the normal production or release of ADH from the pituitary gland or hypothalamus.
Even things not directly in the brain.
Yes, even conditions like Guillain-Barré syndrome, which mainly affects peripheral nerves, can sometimes be linked to SIADH. So, yeah, anything significantly impacting the nervous system can potentially have this knock-on effect on fluid balance.
Okay. Then pulmonary diseases, lung issues. That connection seems less obvious. Why would a lung problem affect a kidney hormone?
That's a great question, and the mechanisms aren't always crystal clear. But we see SIADH linked with quite common lung conditions. Pneumonia, for example, both bacterial and viral.
Really? Pneumonia?
Yes, and tuberculosis, issues related to COPD, even sometimes asthma. It's thought that inflammation or stress signals from the lungs can somehow trigger ADH release.
Huh?
But a really significant link, especially important to check for, is with certain types of lung cancer. particularly small cell lung carcinoma.
Why that one specifically?
Because small cell lung cancer is notorious for sometimes producing ADH itself. It's what we call an ectopic source.
Yeah.
The hormone is being made somewhere other than the pituitary gland. The tumor cells themselves are churning it out.
Wow, the tumor makes the hormone. That's something else. And it's not just lung cancer, right? You mentioned other malignancies.
Correct. While small cell lung is the classic example, other cancers can do it too. Pancreatic cancer, cancers in the head and neck region, bladder cancer, lymphomas, thymomas. It's less common than with small cell, but definitely happens. Tumors can be surprisingly hormonally active.
Okay, now this next category, drugs. This feels very relevant because so many people take medications, sometimes several.
It's a big one.
Hmm.
And quite a few common drug classes are implicated.
Like what?
Certain antidepressants, particularly SSRIs and tricyclics, some antipsychotic medications, things like haloperidol, carbamazepine pops up here too, though it's also used for seizures and nerve pain.
Right.
Then you have chemotherapy drugs, vincristine. Cyclophosphamines are known culprits. And perhaps surprisingly, even common painkillers like opioids and NSAIDs, non-steroidal anti-inflammatories.
NSAIDs, like ibuprofen.
Potentially, yes, though it's less common than with others. And even the recreational drug MPMA, or ecstasy, is a known trigger for acute, sometimes dangerous, SIADH.
Goodness. That's a worrying list. It really highlights you need to tell your doctor about everything you're taking, even over-the-counter stuff.
Absolutely crucial. And then we have that other causes category, kind of a catch-all.
Sort of. It includes things like the body's stress response after major surgery. Significant pain or nausea can also stimulate ADH release.
Makes sense. Stress hormones flying around. Exactly. Certain infections like HIV can be associated with it too. And sometimes, particularly in older adults, a specific cause just can't be found. We call that idiopathic SIADH.
So it really covers a huge range of possibilities. Now, with all these potential triggers, what might someone actually notice? What are the symptoms, the clinical features?
Well, the key thing is that symptoms really depend on two factors: how low the sodium level actually gets, and crucially, how fast it drops.
Ah, so a slow drift downwards might be different from a sudden plunge.
Precisely. A gradual decrease might cause fairly mild, maybe vague symptoms. A rapid drop is usually much more dramatic and dangerous.
Okay, so what are we talking about symptom-wise?
In the mild range, maybe sodium between 125 and 135
Yep.
milliequivalents per liter, that's the unit. You might get things like fatigue, maybe some nausea, headache, just feeling a bit off.
Kind of non-specific stuff, easy to brush off.
Very easy. As it gets into the moderate range, say 115 to 125, symptoms often become more pronounced. Confusion can start, muscle cramps, loss of appetite.
Okay, getting more noticeable.
Yes. And then below 115 is considered severe hyponatremia. This is where the really dangerous neurological effects happen. Seizures, decreased consciousness, potentially slipping into a coma, respiratory arrest. It can be life-threatening.
That sounds incredibly serious. Is there anything doctors look for physically, apart from asking about symptoms, that helps point towards SIADH specifically?
Yes, and this is a really key point for diagnosis. People with SIADH typically don't have edema that's swelling, like puffy ankles, often seen in heart failure. And they also don't usually show signs of dehydration or volume depletion, like low blood pressure or poor skin turgor. They are generally assessed as being euvolemic, having a normal amount of total body fluid.
So they're not overloaded with fluid causing swelling, and they're not dehydrated. It's purely this water-sodium ratio that's wrong.
Exactly. That absence of edema or signs of dehydration is a critical clue that differentiates SIADH from other causes of low sodium where fluid volume is abnormal, like heart failure or severe dehydration itself.
Got it. So if SIADH is suspected, what's the actual diagnostic process? What tests confirm it?
It relies on a specific pattern of lab results from blood and urine tests. Essentially, the diagnostic criteria, often called the Barter and Schwartz criteria, boil down to a few key findings.
Which are?
First, you need to confirm low sodium in the blood hyponatremia, and alongside that, low osmolality in the blood is dilute.
Okay, dilute blood. Check.
But then, and this is the crucial inappropriate part, the urine is not dilute. The urine osmolality is higher than you'd expect for someone with dilute blood. Typically, it's above 100 millimoles per kilogram.
The paradox again, low concentration in blood, high concentration in urine.
Precisely. And linked to that, you usually find a relatively high amount of sodium being lost in the urine, typically a urine sodium concentration over 40 milliequivalents per liter, assuming normal salt intake.
Even though the blood sodium is low.
Correct. And finally, you need to confirm that the person is euvolemic, as we discussed, and very importantly, rule out other potential causes like kidney disease, adrenal insufficiency, or hypothyroidism, because those can also cause low sodium but need different treatment.
So checking thyroid and adrenal hormone levels is usually part of the workup.
Yes, standard practice. TSH for thyroid, often a cortisol level for adrenal function.
Okay, so blood and urine tests are the cornerstone. Any other investigations needed, maybe to find that underlying cause?
Definitely. Once SIADH is confirmed biochemically, the hunt for the cause begins. Depending on the person's history and symptoms, this might involve more blood tests, checking kidney function, glucose, etc.
In imaging.
Imaging is often key. A chest x-ray is common, looking for any lung issues like infections or, importantly, a tumor.
Especially that small cell lung cancer.
Exactly. And if a central nervous system cause is suspected, maybe based on neurological symptoms or history, then a brain scan, usually an MRI, might be done.
Okay, so diagnosis confirmed, maybe the cause identified.
Okay.
What's the treatment plan? How do you fix this?
Treatment strategy really depends heavily on severity and whether the person has symptoms, especially neurological ones.
Right, you mentioned the rapid drop being dangerous.
Yes. So for acute symptomatic hyponatremia, someone having seizures, for example, is a medical emergency. The immediate goal is to raise the blood sodium level cautiously.
How's that done?
Yeah.
Saltwater 5.
Essentially, yes. Using hypertonic saline, which is a concentrated SART solution given intravenously. But, and this is absolutely critical of that, the correction must be done slowly and carefully.
Why slowly? Wouldn't you want to fix it fast?
Because correcting sodium too quickly can cause a devastating neurological complication called osmotic demyelination syndrome, or ODS. It used to be called central pontine myelinolysis.
What is that?
It's basically damage to the protective sheath around nerve fibers, particularly in the brainstem, caused by rapid shifts in water balance within brain cells. It can lead to severe, often permanent neurological damage, paralysis, difficulty swallowing, coma.
Wow, so raising the sodium is vital, but doing it too fast is incredibly dangerous.
Exactly. It's a very fine balance. The guidelines generally aim to raise the sodium level by only about 4 to 6 points, MEQL, in the first 6 hours, and not more than maybe 8 to 10 points in the total first 24 hours. It needs very close monitoring in a hospital setting. The Goldilocks approach, not too fast, not too slow.
Understood. A real tightrope walk. What about the less severe cases? Chronic SIADH, maybe someone diagnosed but without major symptoms.
For chronic or asymptomatic cases, the first line of treatment is usually much simpler. Fluid restriction.
Just drinking less?
Yes. By limiting total daily fluid intake, often to somewhere between 500 and 1,000 milliliters. So maybe 2 to 4 glasses total in a day.
That sounds tough.
It can be very challenging, but the idea is to reduce the amount of excess water coming in, which helps the body gradually raise its sodium concentration naturally.
Does that usually work on its own?
For many milder cases, yes, or at least it helps significantly. But if fluid restriction isn't enough, or if someone just can't stick to it, then medications come into play.
What kind of medications?
One option is dimethylcycline. It's actually an antibiotic, but it has a side effect of making the kidneys less responsive to ADH.
So it directly counteracts the hormone's effect.
Right. But it can potentially be toxic to the kidneys, so it needs careful monitoring and isn't used lightly. Then there's a newer class of drugs called vaptins.
Vaptins.
Yes, these are vasopressin receptor antagonists. They specifically block the receptor that ADH binds to in the kidneys. Very effective, but again, there's a risk of correcting sodium too quickly if not managed carefully, especially when starting them.
Similar risk to the hypertonic saline, then.
Similar caution needed, yes. Another option sometimes used is urea. Taken orally, it acts as an osmotic agent, helping to pull excess water out into the urine.
Urea. Interesting.
And in some situations, particularly if fluid restriction isn't fully effective, doctors might try a combination of salt tablets to increase sodium intake along with a loop diuretic.
A diuretic. Wouldn't that make you lose sodium?
Loop diuretics do make you lose sodium, but they interfere with the kidney's ability to concentrate urine, making you excrete relatively more water than salt compared to what's happening in SIADH. So combined with salt tablets, it can sometimes help raise the blood sodium level. It's more of a secondary approach.
Okay. And underlying all this, I assume, is treating the original cause if you found one.
Absolutely essential. If it's a drug causing it, stop the drug if possible. If it's an infection, treat the infection. If it's a tumor, treating the cancer with surgery, chemo, or radiation is key to resolving the SIADH long term. Addressing the root cause is paramount.
We've touched on the big complications, the severe low sodium effects like seizures and that osmotic demyelination from fixing it too fast. Are there other, maybe longer term things to be aware of?
Well, besides those acute dangers, there is some evidence suggesting that even chronic, milder hyponatremia might have subtle long-term effects on cognition, attention, and maybe even increase the risk of falls, especially in the elderly. So proper management is important even if symptoms aren't dramatic.
Right. It's not just about avoiding the immediate crisis. Now, just to clarify the diagnostic picture again, when doctors are considering SIADH, what other conditions are they trying to distinguish it from? What's on that differential diagnosis list?
Good point. They need to differentiate SIADH from other things that cause hyponatremia. We mentioned some already. There's hypovolemic hyponatremia, low sodium, due to losing both salt and water, like from severe vomiting, diarrhea, or overuse of diuretics, where the person is clearly dehydrated.
Okay, so volume down.
Right. Then there's hypervolemic hyponatremia, low sodium, but with too much total body fluid causing edema. This is typical of conditions like congestive heart failure, liver cirrhosis, or severe kidney disease, nephrotic syndrome.
Volume up, causing swelling.
Exactly. And SIADH is generally euvolemic, normal volume status, no significant edema or dehydration. And finally, as we said, they need to rule out endocrine causes like adrenal insufficiency, Addison's disease, and severe hypothyroidism, as these hormonal problems can also cause low sodium through different mechanisms.
So it really comes down to looking at the whole picture. The sodium level, the blood and urine concentration, the person's fluid volume status, and ruling out those other major culprits.
Precisely. It's putting all those clinical and laboratory puzzle pieces together to identify that specific pattern of SIADH. Then you can tailor the treatment, manage the sodium correction safely, and importantly, search for and treat that underlying cause.
Well, this has certainly been an illuminating deep dive. We started with what seemed like maybe just retaining a bit too much water, but we've uncovered this really complex interplay of hormones, electrolytes, and fluid balance.
It's definitely intricate.
And the range of things that can trigger it, from brain injuries to common medications to hidden cancers, is quite startling. It really underscores the importance of careful diagnosis and that very cautious management, especially regarding how quickly sodium levels are changed.
Couldn't agree more.
Considering how many seemingly unconnected things, a lung infection, a certain pill, stress can disrupt this delicate fluid and salt balance, it really makes you pause and think, doesn't it? It makes you wonder just how profoundly interconnected all the systems in our body truly are, and perhaps what other, maybe even smaller hormonal shifts could be having unexpected widespread effects we don't fully appreciate yet.
That's a fascinating thought to end on. The body's signaling network is incredibly complex.